All right, it's very nice to be here tonight. My pleasure to talk about this. This is an area that I'm really passionate about. So I want to start with a show of hands. So, number of people in the audience who have ever taken a medicine and had a bad reaction to it. All right. Second question: number of people in the audience who have ever been prescribed a medicine and it didn't actually work for what they wanted it to work for. All right. So I think at this point, almost everybody in the audience put up their hand to one of those two questions, and that's really the question that we were trying to answer: is why is that? Why don't the medicines that we prescribe work the way that we want them to work as often as they should? And why do these medicines that we prescribe cause so many bad effects, so many adverse effects in patients? And when I was training to become a physician, this question really interested me. I said, can't we do better, right? Now it's 2016. Can't we have better precision in the way we prescribe? Can't we know whether the drug we give to you is going to work for you and whether the drug we give to you is going to be safe for you? And this is a huge problem. I can tell you, for physicians who are in practice, this is probably one of the greatest challenges we face, is that no two patients that come into the clinic are the same, right? That's what makes our human diversity so amazing. But at the same time, it's a therapeutic challenge, right? Physicians don't really know when they give you that prescription whether it's going to work for you, and they don't really know whether it's going to cause an adverse effect. And I can tell you, if you've been in practice long enough as a physician, we all take an oath to first do no harm. We hurt patients, right, by some of the prescriptions we give, and it's not that we're trying to do that, it's not that we miss something, it's just that sometimes drugs don't work the way we want them to work. And I put on this slide also, there's this, not only the cost to the patient or the trial and error that has to happen when you prescribe drugs and you don't get it right the first time, but there's a cost to the medical system by this, right? By inefficient prescribing, and then that patient who has the adverse reaction, they come back to the emergency room, they get all sorts of tests, they get admitted to the hospital, and this drives up downstream costs for all of us. So can we do better? So all physicians face this, what I call a clinical decision calculus, which means you're at that point, you have the patient sitting in front of you, and you need to treat their condition now. And you might have one of several choices of drugs that you could use to prescribe for that patient to try to treat their condition. And you really don't know which one might be right for that patient. You're trying to use everything you've learned to personalize that treatment, and we use all sorts of personalized factors every day. But I think in 2016, we can add now the genetic component, the knowledge about your specific DNA, and say this medicine might be more likely to be right for you, or this medicine might be more likely to harm you. And there's many examples of this, so just to provide one. So the most commonly prescribed cholesterol drug in the US, I bet many of you in the audience are on it, it's a drug called simvastatin. We now have a genetic marker that can tell whether you're more higher risk than an average person of developing muscle aches, which is the most limiting side effect of this drug. And when I talk to patient audiences and physician audiences, I ask them, how many of you would really want to know whether you're at a higher risk than an average person for having this bad effect from this drug? And every hand in the audience goes up, because why wouldn't we want to know that information? Or one of the most commonly prescribed blood thinners that's on the market. We know that 1 out of every 4 of us can't properly activate that drug in our body to make it work properly. It won't work properly for that 1 out of every 4 of us. And again, patients and doctors ask me, well, why wouldn't I want to know that information before I prescribe that drug? Wouldn't I prescribe one of the alternatives for patients? And so that's how we're trying to use this. And yet when I talk to physician audiences, I talk before thousands of physicians, I say, how many of you ever ordered a genetic test or used genetic information before you've written a prescription? A few hands will go up out of the thousands of doctors in the audience. And I wonder, why is that? Right? And there's lots of barriers why this has happened. Right? The knowledge is somewhat new. There's a cost of doing these tests, and we're not sure who's going to pay for it yet. There's the time delay, right? You order one of these tests, and it could take days or weeks for your result to come back, but the patient wants the prescription right now. And then, of course, there's uncertainty, right? All this information is newer, and physicians are having to learn it on the fly. So how do we solve these barriers so we can bring this type of information to the point of care? And that's what we really set out to do. So when Dr. Retain hired me onto the faculty at the University of Chicago, he alluded to this. He said, Peter, do you think you could solve this problem? And I said, this sounds like fun. I think this is something that's worthwhile for the human race. We could try to solve this. So we created this project. We call it the 1,200 Patients Project. It's at the University of Chicago. There's some other institutions that are trying to do the same thing. We're not the only ones. But we thought we had a really interesting and novel model, and that was convince patients to give us a single DNA sample, and we would test that sample across a bunch of markers that we thought were important for determining how they would react to drugs. They didn't even have to be on that drug right now, because we're going to do the test now, and then it's usable for a lifetime. The DNA that we're all born with doesn't change. And so we do the test once, and then whether they're going to prescribe that simvastatin drug that I mentioned tomorrow, or a year from now, or 10 years from now, then the physician already has the information. And we said, well, how would we actually do this? If patients are willing to sign up, how would we actually then deliver this information at the point of care? So these are the parts of the model that we thought were important. We had to have patients who were willing to give us the sample. We had to have physicians that were willing to integrate genetic information along with all the other factors that go into making a personalized prescribing choice. And we had to have a system, an informatics system, that could put this at the point of care. That's what we call our genomic prescribing system. And that's what I'm showing here in the middle. And so we thought the output should be you get the right dose or the right drug for that individual patient that you're seeing. So this is an actual screenshot from our genomic prescribing system. It's been in use now for almost 5 years at the University of Chicago. We've got about 20 physicians that are using it. It's not every physician. We purposely started with a small group of doctors because we really wanted to learn what worked and what didn't work when physicians tried this. We have over 1,200 patients now in the project that have agreed to be in this. Our adoption rate was extremely high. Almost 90% of patients that we asked, do you want to be in this program, said yes. So patients saw a little downside in having this information. And here's what we actually give to the physician. So the physician logs into this system and they can see, using a very recognizable symbol, the traffic light symbol, whether this information for them is genetically favorable or genetically risky. So the green lights in the system mean that this specific drug for this specific patient that we're showing is favorable for the patient. There's a low chance of side effects or a high chance that the drug will work as it's intended. Yellow lights indicate some increased caution, meaning the patient has some increased risk of a side effect or a lower chance that the drug might work. And then the red lights are those really high risk alerts in the system where there's a very high chance that the patient can have some severe outcome from that drug or a very low chance that the drug would work. We code all these with a level of evidence. It's all based on published information that has been done in human beings showing these effects based on genetics. And the part that our physicians like the best is on the far right. Because we did the test preemptively, right? We tested them for all the markers, for all the drugs that have actionable information. We can tell them, well, here's some alternatives you might try. So for example, if a patient comes in and they're on this drug, hydrochlorothiazide, which lowers blood pressure, and they say, you know what, my patient's blood pressure is not very well controlled. Well, it turns out this yellow light actually indicates that. It says that there's some genetic marker in that patient that makes hydrochlorothiazide not work as well. And the doc can say, well, you know what, I want to change the prescription. We've already given them 8 other drugs that treat high blood pressure that would be genetically favorable for this patient. So has this actually worked? So we've been doing this, like I said, for almost 5 years now. We've looked at over 3,000 visits where patients have come back to see their physicians, and the physicians have had the opportunity to use the system. But we didn't take for granted that physicians would even have time to do this, and yet they're using the system at a rate of about 70%. 70% of the time that the patients come in, the doc says, I want to look at the genetics before I make a prescription. And we notice they're changing what they do. So patients that were on red light drugs, the docs change them most of the time. 60% of the time, they say, we're going to take you off this drug and put you on a safer one, predicted by genetics. And I'm always asked by audience, well, why wouldn't it be 100% of the time for these red lights? And I can tell you a lot of these red light drugs just indicate that certain drugs might be at very low levels in the bloodstream. They might not work as well, and our docs tell us, we go back to the patient and we say, is this drug helping you? And if the patient says yes, they keep them on. That's the whole idea. Genetics just gives some direction for the physician to ask the right question. We do notice that our yellow lights are being changed more frequently than the green light, the safer green light drugs. And of course, there's many drugs that still don't have pharmacogenomic information, there's genetic information, so there's lots more research that has to be done. I thought one of the most compelling things we learned is that when doctors prescribe a new drug and they have the available information in our system, over half the time the physicians tell us that their choice of that new medicine was influenced by the information we gave them. And on the other side of the coin, 2/3 of the time when doctors are stopping medicines that their patients are taking, they're telling us that they stopped that drug because of this genetic information that we were able to provide. These are powerful numbers to us, telling us that the docs are really responding to the type of information. They're excited to have it for use in their practice. So where do we go from here? So certainly we need to show this in a larger number of patients and physicians. But we had many physicians that say, no, I don't really need to see any more data about this. Why wouldn't I want to use this all the time now? And that's really what led to UCTech wanting to say, can we get this into the hands of more physicians and practices all across the country and the world? We really want to show that we are decreasing adverse events, or these bad effects that patients have from medicines, and we want to show that we're increasing the chance of you responding from drugs. And there's really more research that needs to be done to show that. And then lastly, we've been fortunate enough to receive some innovation funding to really allow adoption to happen more widely. And I think that's exciting because we can publish all the papers we want about this. But what's really going to drive this getting into the hands of physicians and then helping patients is having lots of doctors have this accessible to them. So I put up here that you can learn more about this. This is our research website at the Center for Personalized Therapeutics, and I'm happy to answer questions about this afterward as well. Thanks very much.